Welcome to Public Health Ideas. My name is Sandro Galea. I serve as Dean of the Washington University School of Public Health. These conversations aim to discuss work that advances the science of health. Today, I have the privilege of speaking with Professor Tim McBride. Dr. McBride is Bernard Becker Professor at the Washington University School of Public Health. Today, we're going to be discussing his paper in the Journal of Rural Health, Policy Implications of Fixed to Total Cost Ratio Variation across Rural and Urban Hospitals. Tim, welcome.
Thank you.
So let's start with where this paper came about. What are the key questions you wanted to answer?
Well, thank you for inviting me and welcome to St. Louis.
Thank you.
And I want to acknowledge first my co-authors, Abby Barker from Brown School and Clint McKinney at the University of Iowa, who did a lot of the lion's share of the work of this. So the paper came about from the question of what's the challenges facing rural hospitals. If you read the paper and if you follow healthcare, you know that since 2010, about 150 rural hospitals have closed in the United States. So one of the possibilities is that they face an unusual amount of costs and that are hard to manage. And so this paper addresses this and sort of probably maybe sounds like a difficult title, but it really deals with what those costs are and are they manageable for rural health, and what tries to break down what the aspects of costs are for rural hospitals to deal with, because when places lose a rural hospital, people lose access to health care.
So you anticipated my question. It is a hard to say title. So tell us, what's a fixed to total cost ratio? What do you mean by that?
Well, thanks for asking that question. So fixed costs are basically costs that are basically invariable to the volume of services that are delivered, like volume of emergency visits, volume of admissions and such. So fixed costs are things like rent and mortgages and administration of the hospitals, those kind of things that don't increase or decrease as the volume of services go up, don't tend to increase like that. Variable costs are things that go up and down as the admissions and to the hospital go up and down. And economists like to say in the long run all costs are variable, but basically the point is that fixed costs in the short run are fixed and they cannot be usually changed. So that's the point. And the fixed to total ratio is how much the fixed costs are as a percentage of the total costs. And the thought is where the fixed costs are higher, it's harder to move costs in the short run.
So that gets to my next question. So I'll read your conclusion, essentially, that hospitals with lower fixed to total cost ratios may be better positioned to remain financially viable when reducing service volumes is required by many value-based payment systems. Can you explain this to us?
Yeah, so I think that's the point is, it's kind of phrased in your question as that point is that if you have a hospital with a high fixed to total cost ratio, when the volume goes up or down, if you have a lot of fixed costs, those aren't going to go down when the volume goes up or down, or they're not going to go up. So it's hard to deal with those fixed costs. The analogy I like to mention is like we've all been through COVID. Mm-hmm. So think about what happened during COVID. One of the first things that happened was a lot of elective procedures were stopped at hospitals. And so if there were fixed costs that were there and they stopped having certain admissions into the hospital, those fixed costs would remain. And it would be very difficult for the hospital to deal with that. But if you had a hospital with a lot of variable costs, you could lower those costs and deal with it better.
That makes sense. That's a helpful analogy.
Yeah.
So you were using the Medicare Hospital Cost Report Information System data. Tell us a little bit about the data and the analysis and what you end up finding.
So the good thing about that data is it's basically data on all the hospitals in the United States. And it's a reporting system where they're required to report their detailed costs at the high level, but also at all service levels for Medicare. But they're also give it for all costs for the hospital. And they're required to do it if they get Medicare patients, and basically every hospital in the United States gets Medicare patients. So this gives us a rich data set to look at all the hospitals in the United States, and it's publicly available data set. So what we basically found was true to our hypothesis that we thought, which is that the fixed cost ratio was a lot higher in rural areas than it was in urban areas, and it varied by the degree of rurality. Say, so, just to cite a couple numbers, the numbers were pretty close to 1, or in the 90% ratio for rural areas and down in the 80% for urban hospitals.
And this is driven by volume? So what's driving this difference?
So a really good point. In a lot of my research and the research Abby and I have done over the years, I would say that, to understand the problem in rural areas, it's important to understand the concept of economies of scale. Basically, I've believed this after working on rural health for about 30 years, that rural areas have difficulty because they're small. So if you have a certain fixed cost and you divide it by a small denominator, you got a problem. But if you have a big area like St. Louis or Boston or something, and you have a much bigger denominator, you can spread those fixed costs more. And that's the concept of economies of scale. As the scale goes up, you're able to spread, say, the cost of the CEO, the cost of the building, and all that over more people. But if you got, you're in a rural area that's got 200 people, it's really a challenge.
As you know, I was a rural doctor earlier in my life, so I resonate with it. Tell us a little bit. In your paper, you actually found this degree of rurality. You actually found your micropolitan areas compared to other counties, and you found difference in this in this ratio that you were looking at. But take that now and give us the bigger picture. Tell us a little bit about the disadvantages that rural hospitals are facing in this country. And you mentioned the closures of rural hospitals earlier, and solutions.
Yeah, so, the solutions have been vexing us for probably decades. And, I work a lot with Capitol Hill, and this is like the first question they ask you is like, how can we deal with this? And the challenge, it really does vary. I'm glad you brought up the degree of rurality, because a lot of times people think in a dichotomous way, urban versus rural, and I don't think that's really the right way to look at it, because, there are various different rural type of areas in the United States, so it matters whether you're a bigger rural area or a remote, small rural area, and if you're in different parts of the country. So that's one thing I would say. And so, I think basically the challenge is if you set up a payment system that's based on average costs, which is what most of our payment systems are, you're going to basically disadvantage small rural hospitals. And that's kind of the major point of this. And so a lot of our payment systems are set up that way. And even some reforms like volume-based system payment reforms might have some challenges. So it comes down to a challenge of, is it really essential that you have these rural hospitals and providers in the place, or do you not necessarily need it? And if you do feel it's essential to have a hospital in every sort of location and not make people move to go get services, then you kind of have to deal with covering this fixed cost issue.
These hospitals are covering what % of the population?
Basically the rural population in the United States is about 20% of the population, so I don't know off the top of my head.
But roughly we're dealing with about 20% of the population.
Yeah.
So what is a better payment system? If we want to keep, I think your point is a value point. Does it matter to actually have hospitals? And knowing healthcare, delivery of healthcare, but also patients, people do want healthcare at least at some level close to them. So what is an alternative payment structure that could work?
And I'm getting a little bit beyond the paper here, but this is me speaking, from a lot of experience. I sort of think we have to, one thing, I'm on a panel that's talked about this for years. A couple of things we'll say. There are certain essential services that we need to keep local. I think if people feel like they need to have emergency services, maybe OB, delivery services maybe need to be local, because we probably don't want to put a mother in the car and have her drive 100 miles while she's about ready to deliver. I think that's probably problematic. and, maybe some pieces mental health. But, do we need to have every piece of specialty services in every area? Probably not. And is it not a problem to make people drive 60 miles to go to get their specialty services in, say, St. Louis? Probably not. So, but if you agree that it's important to have essential services locally, then you'd have to sort of deal with this fixed cost problem, and maybe I sort of think it's kind of a public good problem that, and I'm not sure we're dealing with that as a country. We have these Byzantine payment systems that are based on historical costs, and it sort of disadvantages certain areas and hospitals. And so to fix that, they've created all sorts of wraparounds and fixes that I think just mess the whole system up, frankly, as an economist, and create all sorts of weird incentives. I think they should just hit the problem head on and basically say, we think it's important to have services everywhere, and these are the ones we want. Other ones, we may not subsidize.
So where does this work go? What's next?
I think the whole issue of economies of scale and fixed costs and all that permeates a lot of my research, and a lot of my colleagues, we apply it to thinking about insurance. A lot of my work is in the insurance area. I think the same kind of principles apply to thinking about why it's very difficult to get insurance plans into rural areas, whether it be, Medicare or private insurance plans. So, I think it was important to have this finding around fixed and total costs, and, it would be useful to apply this to other concepts of insurance and all that. We are still working on, the vexing problems of access to care in general. That's really what permeates most of my research.
Thank you. Thank you for the work you do.
Oh, thank you
for joining this conversation.
Yep.
Thank you for joining us.